Hello, and welcome to the ASCO Daily News Podcast. I'm your guest host today, Dr. Mohamed Salem. I'm a GI oncologist at Levine Cancer Institute at Atrium Health. Today, we will be discussing very promising advancement in the neoadjuvant immunotherapy for patients with MSI-H or dMMR colorectal cancer. And I'm very delighted to welcome two world-renowned oncologists whose research has tremendously helped shape the treatment landscape of colorectal cancer. Dr. Myriam Chalabi, she's a GI medical oncologist at the Netherlands Cancer Institute, and Dr. Andrea Cercek, she's a medical oncologist at Memorial Sloan Kettering in the United States. Our full disclosure are available in the transcript of this episode, and disclosure relating to all episodes of podcast are available in our transcript at asco.org/podcast. Dr. Shelby and Dr. Cercek, welcome to the ASCO Daily News Podcast.
Thank you for having me.
Thank you very much for having me.
It's a pleasure to have two world-renowned stars like you. Thank you for taking the time. So before we start going deep in the topic, obviously now we are seeing emerging data in CRC using immunotherapy as neoadjuvant approach, which actually can reduce or even eliminate some of the other treatment modality and potentially save patient toxicity. Both of you led what I think landmark studies in this field. I wanted to give you the chance just to tell our audience about the study and why you think it's important. Dr. Cercek?
Sure, thank you so much. So our study was a neoadjuvant study in early stage locally advanced rectal cancer. It was tumors that were mismatch repair deficient or MSI-H. And rectal cancer normally is treated with chemotherapy, chemoradiation, and surgery. And the goal of the trial was to utilize PD-1 blockade alone in this subpopulation and evaluate the response. So patients received 6 months of dostarlimab, which is a PD-1 blocking agent, and then were evaluated for response. If there was no residual disease, they were able to avoid radiation and surgery. And what we've seen thus far in the presentation at GI ASCO in 2022 was that all patients who received 6 months of dostarlimab had a clinical complete response, so no residual tumor, and were able to avoid chemotherapy, radiation, and surgery and are on observation. And the study is ongoing and actively accruing patients.
All of us were very excited seeing that presentation at ASCO, and we came back to clinic. Everyone was talking about it, including patient, obviously. Thank you, Dr. Cercek, for this. Dr. Shelby, you also led a similar study that was actually presented in ESMO in 2022. Can you please give us like a brief description of that trial?
Yeah, sure. So this is the NICHE trial, and the NICHE trial has been ongoing for quite some time now. We recently presented a larger NICHE-2 study. But basically, so what we started out by doing in NICHE is giving patients what we considered back then a window of opportunity study. We treated patients with MMR deficient tumors, which I'll be focusing on for now, with 2 cycles of nivolumab and 1 single cycle of low-dose ipilimumab. And patients all undergo surgery within 6 weeks of registration within the study. And back in 2020, we published the first data of NICHE-1 showing 100% pathologic responses with 60% pathologic complete responses, and decided that this should definitely be a treatment that we need to explore in a larger group of patients. And that's where NICHE-2 was born, which we presented at ESMO last year, where we treated over 100 patients with this neoadjuvant approach of 2 cycles nivolumab, 1 single cycle of ipilimumab, showing 99% pathologic responses, including 95% major pathologic responses and 67% pathologic complete responses. And this was all within 5.5 weeks of the first treatment with immunotherapy. So a very short treatment duration with dual checkpoint blockade.
Amazing result too. And I know you had a standing ovation when you presented the outcome of the study. And again, congratulations to you, your investigator, and also all the patients participated.
Thank you so much.
I guess the first question come to my mind, we have 2 trials. Obviously, now we're moving from one size fits all to precision therapy, like getting actually the right treatment for the right patient. But in the NICHE study with checkpoint inhibitor, in the rectal study was a single agent. I want to start with you, Dr. Shelby. In your opinion, when should we use single agent or double blockade immunotherapy?
That is a great question. And I'm going to start off by saying that I don't know the exact answer. I don't think we know that answer. And Dr. Cercek is going to share also her thoughts on this because we're seeing, of course, fantastic responses with monotherapy as well in Dr. Cercek's study. And we've also seen that in a study by Dr. Overman with monotherapy. So that may suffice in some patients, although what we're seeing is that you need to treat patients longer, probably to achieve that response, at least clinically. And I think that is the difference with dual checkpoint blockade that we're giving in niche, where we're seeing these very deep responses in just under 6 weeks' time. So I think it may be more of a question of how long we want to treat patients for to achieve the endpoint that we're aiming for. And of course, there may be at some point patients that need dual checkpoint blockade, but so far we're seeing great responses in both of our studies. So I think we need more patients, more data to see whether we're going to see non-responders, and hopefully the studies that are ongoing in the metastatic disease setting will give us at least a little bit of insight into what the differences are in response to mono and dual checkpoint blockade and whether we can tell which patients might benefit more from the combination. But there's a lot of work to be done in that field, I think, still.
Totally agree. Dr. Cercek, same question to you. What do you think?
Dr. Chalabi answered beautifully and very comprehensively. I agree completely with what she said. It's hard to argue with the responses that we're seeing with PD-1 blockade alone. But then again, dual checkpoint inhibitors in the niche study with just 1 month of therapy had phenomenal responses as well. So I think it's a question of duration of therapy and really importantly, what we're trying to achieve. If our goal is organ preservation, then perhaps longer duration is better. The question then becomes, should we do longer duration with dual checkpoint inhibitors versus single agent? So I think as she concluded, I couldn't agree more that we just need more information. We need more work to do basically to answer this question for our patients.
More to come and more studies, which is fascinating. So Dr. Chalabi, you created actually a new term in Twitter called Chalabi blood. It was amazing to see such a response. But we're curious, among those patients who achieve complete response, so far, did you see any relapse?
Short answer, no. So we're waiting, of course, on the disease-free survival data, the 3-year DFS data for niche 2. And we hope to have that by the end of this year, beginning of next year. But at ESMO, we showed that data, and so far we haven't seen any recurrences in actually any of the patients treated in niche 2.
Fantastic. Dr. Cercek, so I think your slide, I remember clearly in ASCO presentation, was like all complete response, every single patient. Same question, did you see any relapse so far?
So far, no, we have not.
Wow, amazing. So Dr. Cercek, as you know, and obviously this is metastatic disease, but in Keynote 177, as you know, like about 30% of patients with MSI-H tumor did not respond to checkpoint inhibitor. So that makes some of us feel nervous about using checkpoint inhibitor alone in colorectal cancer, even with MSI-H status. I was curious if you can comment on this and if there is a way we can perhaps sort out who actually patient likely respond and who likely not going to respond.
I think that's a really important question and, an excellent point. And we believe that the difference lies in the fact that in Keynote 177, the patients had metastatic disease, whereas in our neoadjuvant studies that we're discussing, they have early stage disease. And whether that has to do with the tumor differences, young tumors versus older tumors once they become metastatic, or the microenvironment remains to be determined. But certainly there is this pattern of incredible responses with checkpoint inhibitors in early stage dMMR tumors. And in Keynote 177, as you mentioned, about 30% of patients progressed. And I think we don't know why that is. We are seeing this about a third progressors repeatedly in the metastatic setting with checkpoint inhibitors. And so perhaps there is, a population, but whether that is driven by genomics or something else, we don't know.
Along the same lines, especially in rectal cancer, obviously because surgical resection is a key component in the treatment paradigm, do you feel patients who achieve pathological complete response should still go under surgical resection or should go under the watch and wait approach?
In general, I'm a fan of organ preservation. I think in rectal cancer, the reasons are obvious. It's a challenging surgery. It's very toxic to the patients. It changes their lives forever in survivorship. 30% of them require a permanent colostomy because of the location of the tumor. So there, the field of rectal cancer in general is moving towards non-operative management, even in mismatch repair proficient patients, by trying to optimize therapy to increase clinical complete responses and therefore omit surgery. So that's the difference with rectal cancer. In colon cancer, it's a different discussion. I think for many patients, surgery is very straightforward. It's a hemicolectomy. It doesn't alter lifestyle in survivorship. So it's not as morbid as it is in rectal cancer. Of course, I think if a patient is older with mismatch repair deficient tumor, perhaps can undergo surgery, then clinical complete responses become critical because then we can monitor them after just checkpoint blockade and they don't need surgery. The challenge there, and I would love to hear Dr. Chalabi's comments on this too, is just that imaging is challenging. We have a hard time in colon cancer determining whether someone has a clinical complete response or not. It seems to be very different than in rectal cancer, where with endoscopy and with the rectal MRI, we really can tell whether the tumor is still present or not. This remains a challenge in colon cancer.
Dr. Chalabi, I would like to hear your thoughts and also how you guys practice in Europe. I don't know if it's the same like in US or different.
I completely agree with Dr. Cercek. Well, if we look at the rectal cancer patients, I think this is fantastic that even though this is a small population, achieving this high clinical complete response rate, not having to operate or even give any chemotherapy or radiation therapy to these patients is extremely important, both in the short term, but also in terms of long-term complications and morbidity. When it comes to the colon cancer responses that we're seeing in niche, those are all pathologic responses, of course. And we have been evaluating also pre-operatively using scans to see whether we can assess these complete responses based on imaging. That doesn't seem to be the case. We do see responses in all patients. So we see these are all very large, bulky tumors that we're treating in niche 2. And we do see responses in almost all of these patients, but it's not close to complete responses. Definitely not in all of the complete responders that we're seeing. So that makes it difficult. And the question is, what if we would be waiting or treating longer because these bulky tumors need more time to disappear or to be cleared before you're going to see it on imaging? So that is a question that I don't have an answer to just yet. We may be getting some more data on that with the currently ongoing trials. And as Dr. Cercek pointed out, the endoscopies, when you have a right-sided colon tumor, is different than doing just a sigmoidoscopy for a rectal tumor. So we actually do have one patient that hasn't undergone surgery, and that is actually a patient with an MMR proficient tumor within the niche trial who had a complete response. And that patient has a sigmoidal tumor. And he actually had toxicities which prevented him from undergoing surgery timely, and now has a complete response after 2 years, both endoscopically and on imaging. So he hasn't undergone surgery. And that is a great example of how we may be doing this in the future. So it's an interesting case within the trial to follow and see how we can do it in the future.
That's fascinating news. So you said was MMR proficient?
Yes, this is an MMR proficient tumor. Yeah.
Wow. Any particular biomarkers that you think he or she had to predict that?
We have treated more patients with MMR proficient tumors. We have 31 patients, and we have seen actually responses in 9 out of 31 patients in the MMR proficient tumors with the same combination of 2 doses of nivolumab and 1 of ipilimumab. And we previously published on half of the cohort approximately on what the possible predictive biomarkers of response could be, and that was a co-stain for CD8 and PD1, so PD1 positive CD8 T cells. And we're currently doing the same work for the rest of the cohort. So hopefully we'll be able to show that soon and see whether this still stands for the completed MMR proficient cohort. But definitely also very exciting data for the MMR proficient.
So this is actually a very good segue to my next question, because I know all of us looking for this. Obviously, we're seeing a fascinating response in those patients with MSI-H tumor. But majority of colorectal cancer, as you know, they actually have MSS or proficient tumor. Any thoughts about how we can overcome the primary resistance for this tumor to checkpoint inhibitor? So let me start with you, Dr. Cercek, first.
So I'm very much looking forward to Dr. Chalabi's data on this because honestly, we have not seen such amazing responses to immunotherapy in MSS tumors. The initial studies were complete flatline, no responses at all. And here, she just described a patient that had a complete response to just a month of checkpoint inhibitors. So that's phenomenal. And hopefully we'll learn from the responders. We believe that there is a subpopulation of MSS colorectal cancer that is more immune sensitive, immune hot, whichever term you like to use. And it's just a matter of appropriately identifying those patients. And personally, I think the answer lies in the neoadjuvant setting in early tumors where they're treatment naive, not exposed to chemo, not exposed to radiation, younger, have their innate microenvironment. And so I think it's likely a combination of the above, but obviously the ultimate goal is to find out who those patients are and then potentially treat them just like this with immunotherapy. And, that would be another nice chunk of the pie where we could utilize immunotherapy for our patients.
Very true. Dr. Chalabi, especially with your experience and just showing there is a chance for those people to respond, what are your thoughts about how we can overcome this primary resistance?
It's great to be here with Dr. Cercek because obviously we have very similar interests, but it's also good to see that we think the same way because I completely agree with what she just said in terms of neoadjuvant. I think that was one of the most important things that we did here. Giving this neoadjuvant treatment in non-metastatic tumors is probably a very important driver in the responses that we're seeing. So we've been seeing data now a bit more in the metastatic disease setting where MSS tumors seem to be responding to new generations of checkpoint blockade. And the question is how those would do in the neoadjuvant setting, if that would be even different than what we're seeing now. But there's definitely a subgroup of MSS tumors that can respond to immunotherapy. The question on how to overcome the primary resistance, I think that the question is first, who are the patients with primary resistant tumors? And why are they primarily resistant? And then we can think about how to change that and how to change them into the tumors that are responding. So I think these types of data will be key to understand more and, hopefully even use that in the metastatic disease setting to make these tumors more viable to respond to immunotherapy.
I agree. So both of you are leading us to how to choose the right patient with the right target for the right treatment. That's an amazing journey you're taking all of us on. So, Dr. Cercek, I have to admit that with your data, it created some problem for us in the clinic because all patients the following day came and asking for immunotherapy. We had hard time trying to explain that maybe is it not the right treatment for them or not the right platform. But I wanted to ask you, if we'll have a patient tomorrow in the clinic with localized rectal cancer and happen to have MSI-H tumor, what would be your recommendation in terms of how to approach that patient?
I think ideally you would discuss the clinical trial with the patient. We have opened this study now to not just rectal cancer, but colon cancer, and in fact, all solid tumors that are mismatch repair deficient. So I think at this time, the patients really should be treated on a clinical trial as we learn more, and in particular, until we are more comfortable assessing for a clinical complete response and follow-up. I think the surveillance piece will be critically important. In rectal cancer, it's well established, but it's not in the other tumor types. So my recommendation would be to enroll the patient on a trial.
I agree. And just to add to that too, obviously, as you know, there is now the cooperative group trials that looking at that option, and obviously we encourage all centers to participate and open that study to have this option for our patient.
Yeah, absolutely.
And Dr. Chalabi, so what do you guys do in Europe and Netherlands for those patients too?
In Europe, it's a very different situation. I would have answered this question differently by saying, well, we don't have that option of treating patients outside of clinical trials. So basically, we have to make sure that we have clinical trials for these patients. And that's something that we've had for colon cancer patients. That is still the case. And we're getting rectal cancer trials also for patients with MMR deficient tumors and have those also for MMR proficient tumors. For us, and I agree completely that we should be treating patients within clinical trials. We don't have another option, but still, even if we did, I think it's important to create data within clinical trials to be able to ultimately also show why this should be standard of care and how we can make it standard of care. Because if you're not accumulating that data, then it's going to become very difficult if accrual is lacking. Now we treat patients either with standard of care treatments, but usually we try to find something within clinical trial.
I totally agree. And as we always say, the standard of care should be a clinical trial participation. So I must say, both of you, Dr. Cercek and Dr. Chalabi, you made 2022 a very exciting year for us in GI cancer. You really changed the way we look at how to treat this patient and give them a huge chance of, I would say, actually cure and obviously organ preservation. So I'm very curious to know what you guys are working on now and what we should expect in 2023 and 2024.
So for me, the study is ongoing, as I mentioned, and we've expanded to all mismatch repair deficient solid tumors with the same approach of 6 months of dostarlimab and then the option of non-operative management. And I think that'll be important for us to learn in terms of responses, endoluminal versus some of the other tumor types, like, for example, pancreas cancer, where we don't see these robust responses in the metastatic setting. That'll be important to do. We're doing some correlative analyses, as Dr. Chalabi described as well, in our patients. And then I'm interested in optimizing neoadjuvant approaches to minimize therapy in rectal cancer specifically. So we have a study now for HER2 amplified RAS wild type patients with locally advanced rectal cancer with a similar approach of utilizing HER2 targeted therapy first and then in combination with chemotherapy. In our case, it's a combination of trastuzumab and tucatinib, and then chemotherapy with CAPOX, and assessing for response and potential omission of radiation and surgery, depending on responder. So I'm very excited. That study is open and actively accruing, and hopefully we can get similar responses that we did in the MSI population with PD-1 blockade.
Is that only available at Sloan?
It is at this time. However, we will likely be expanding. So if there's any interest, let me know.
What about you, Dr. Chalabi? Any sneak peek in the future?
So many sneak peeks, where to begin? I think it's very exciting to be working in this space at this time, and we're very lucky to be within it. So for niche, we're actually accruing now in new cohorts for both MMR deficient and MMR proficient tumors. For the patients with MMR deficient tumors, we're actually testing a new combination of nivolumab plus relatlimab, so anti-LAG-3 plus anti-PD-1. And we're testing the same co-formulation in patients with pMMR tumors, in addition to another cohort for the pMMR tumors with nivolumab anti-interleukin-8, all within this window of opportunity as we did previously in niche, and to see if we're going to see more responses, if these are going to be different tumors than the ones responding to nivolumab, ipilimumab. And for the MMR deficient tumors, we're treating longer with this combination now. So we're operating after 8 weeks instead of 6 weeks. We're giving 2 cycles, 4 weekly cycles, to see whether we can even improve the PCR rates, even though this is, of course, a different combination treatment. So very exciting times for niche, and we'll have the readout for the DFS at the end of this year. So that's also very exciting. And then, a bit similar to Dr. Cercek. So again, we're on the same page when it comes to these neoadjuvant treatments. And we have actually an ongoing trial for neoadjuvant treatment of patients with MMR proficient rectal cancers. And that is using the combination of radiation therapy followed by a combination of atezolizumab, so anti-PD-L1, with bevacizumab, with the aim of organ-sparing approach in these patients. And we actually presented stage 1 of this trial as a poster at ASCO GI, showing that we achieve 56% complete or near complete responses clinically at 12 weeks. And after a year, at least a year follow-up, of all patients, we have 50% organs preservation. So those are very exciting data as well. Also in the MMR proficient tumors, I'm very excited to hear about the HER2 positive tumors in Dr. Cercek's study. So there's definitely a lot going on that we hope to share as soon as the data are available.
We'll be looking forward to your next presentation and seeing that. So you truly, again, both of you and your work showed us that we really have to choose the right patient with the right target for the right treatment to achieve the best possible outcome. So we're getting short on time here, but before we conclude, ASCO Daily News Podcast have a huge audience with oncologists. I wanted to give you the chance to share anything you'd like to share with our audience today before we finish. Dr. Cercek?
I believe this is an incredibly exciting time in colorectal cancer. I think it's, finally our turn, which feels really nice. And obviously we have a lot more work that needs to be done. But my personal belief is to, keep trying to chip away at the pie and identify responders and keep working to have better targeted drugs and better treatment options that will improve responses and improve outcomes for our patients. But I certainly believe that we are well on our way there, and it's very exciting.
I totally agree. Dr. Chalabi, any last thoughts?
I think after 2022 and the data that we've been showing, I think it's important to, and I think by now maybe it's not even necessary anymore to say it, but I think it's important to really look at the tumors and look at these MMR proteins or MSI and to make sure that you're treating the patient in the right way and to consider that. Before, it wasn't as important in the neoadjuvant setting or these localized tumors, but now it's becoming essential. And I think if you would have looked 5 years ago and you would say, yeah, these MSI tumors are important to find, then, it's a very small proportion of patients in rectal cancer, even lower than in colon cancer, but still it has such a huge impact on what you're doing in these patients and your chances of cure. So I think that would be my most important giveaway, to test for MMR deficiency before deciding on a treatment for your patients. And we're working on trials with neoadjuvant immunotherapy also in other tumor types. Dr. Cercek is also doing the same. So I think those will be very important also outside of the GI field to see whether this approach works for a much larger patient population, despite the low incidence.
Dr. Chalabi just made a critical point that is most important, is to remember that we do have biomarkers in colorectal cancer that in the neoadjuvant setting and in the metastatic setting, especially MSI, that we need to test for. And then just to add, from a clinical perspective, in rectal cancer, the large majority of patients that have mismatch repair deficient or MSI tumors actually have Lynch syndrome. So it really, if you identify a patient that's mismatch repair deficient or MSI high anywhere, but especially in the rectum, they absolutely should get germline testing.
So first of all, I'd like to thank both of you again for being here today, but more for the great work you are doing, you and your team, to advance the field, and for sharing your insight with us today on the ASCO Daily News Podcast.
Thank you so much for having me. It's been great.
Thank you for having me.
Thanks to our listener for your time today. If you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe whenever you get a podcast. Thank you very much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.